100 years ago, the term carcinoid was coined by a pathologist, and carcinoid is derived from Latin words that mean cancer-like. And it's really interesting that this has evolved over 100 plus years, because we now know that these in fact are cancers. They used to be thought that they were only sort of like cancers, that they couldn't spread, that they were benign. I tell patients that these are in fact cancers. They can grow and spread, which is what defines a cancer.
Neuroendocrine tumors are a type of malignancy which starts from endocrine cells. Even though we usually think endocrine cells belong in endocrine glands, like a pancreas or a thyroid, in addition, endocrine cells are scattered throughout the intestinal tract and lungs and other parts of the body. And if one of these cells undergoes a mutation that makes it malignant, you get a neuroendocrine tumor. Why individuals get them is usually not known. There are occasional cases where it runs in families, but that's actually uncommon.
Don't compare it to any other kind of cancer or any other patient with any other kind of cancer, because everything is different.
Neuroendocrine tumors tend to be much slower growing. I think of them more of a chronic cancer, a chronic disease. And it's really thinking about that in that context. And I think that's just a very different paradigm for both providers and for patients to think about.
Just about everything about neuroendocrine tumors is different from all other kinds of cancers. The size of the primary tumor, the size of the lymph nodes, how many patients have metastatic disease at diagnosis.
NETs are a cancer that can affect patients of all ages. Typically, it is in the 50s and 60s, but I think what we're finding is that we're seeing an increased incidence of NETs that is likely due to improvements in diagnostics, earlier colonoscopies, incidentally discovered on scans, and so we are seeing patients diagnosed at earlier ages. Neuroendocrine tumors are unique in that they can form in almost any part of the body, most commonly in the pancreas, the small intestines, and in the lungs. They form from neuroendocrine cells that are scattered really throughout the body. And cancers are unique in the sense that these cells, any cancer, grow and divide very chaotically and grow fast.
One of the problems is that because this is a rare tumor, it is not appreciated for what it is early on. And often the diagnosis is delayed for many years after people have symptoms. That's really a problem, and we have a big educational effort directed at leading to earlier diagnosis. Somebody might have a neuroendocrine tumor growing in the body for 5 to 10 years before it's ever diagnosed.
For patients with very slow-growing tumors, in many cases they're asymptomatic. In some cases, the tumor is identified as an incidental finding during a workup for another problem that a person had. In other cases, if it's a small bowel tumor, sometimes patients will present with a bowel obstruction. In other cases, if the tumor is making hormones, then sometimes those hormones are what actually cause symptoms that will bring a patient to receive medical attention. As an example of that might be a pancreas tumor that's making insulin excess, so the patient has low blood sugars, and that can cause a lot of symptoms like dizziness and sweating and other symptoms related to that. Or they could have serotonin excess, as in the case of carcinoid syndrome, where they might have diarrhea or flushing. In contrast, patients with poorly differentiated neuroendocrine carcinomas have often been ill for a relatively short period of time. Sometimes patients will become ill just over a matter of a few weeks. They may have weight loss or pain or discomfort or other symptoms, maybe abnormal lab tests. And usually the clinical course is somewhat more compressed or shortened in that patient, and they're receiving medical attention for symptoms related to the tumor itself, as opposed to being something that was asymptomatic and picked up during other imaging that was done.
The initial challenge will be getting the pathologist to make the right diagnosis. So oftentimes there are pathologists who may also not have a lot of expertise in recognizing neuroendocrine tumors or finding the correct grade. So neuroendocrine tumors are placed into 3 buckets of grade 1, grade 2, and grade 3 that requires looking at a certain minimum number of data elements in a pathology sample. That includes Ki-67, mitotic index, degree of differentiation. So as a neuroendocrine tumor expert, we require that pathology samples be reviewed, sort of a second opinion pathology review, before I even see patients. I think that another challenge, particularly for patients with metastatic NETs, is the chronicity of the disease. Patients may live for many, many years, though that is a blessing. That can also pose a unique challenge. So many patients will tell me maybe they go to an emergency room and they're seen to have many liver metastases, and someone may wrongly assume they have very little time left to live. So it's really a misunderstanding of the disease itself.
For well-differentiated neuroendocrine tumors, I would say far and away the most common tests are just regular cross-sectional imaging with CT scan or MRI to follow patients. We now have gallium-68 dotatate and dotatalk functional imaging, which is now available, which assesses for somatostatin receptor expression. This is a lot more common on the well-differentiated tumors, so we use that pretty routinely for the grade 1 and 2 tumors, and sometimes for the well-differentiated grade 3 tumors. We do some biomarker testing. I would say most commonly it would be hormone testing in people with functional tumors.
One thing that's also different about neuroendocrine tumors than other kinds of gastrointestinal cancers is that the other types of gastrointestinal cancers start on the inside lining of the bowel and have to grow to be quite substantial before they make it to the outside. Neuroendocrine tumors are different. They start toward the outside and they're visible on the outside of the bowel, which is one reason that they elude detection on endoscopies and barium studies and things like that.
Neuroendocrine tumors are very rare. And because of that, most doctors in practice have very little experience with treating neuroendocrine tumors. The treatment plan is ideally developed by a multidisciplinary team that includes specialists in surgery, interventional radiology, oncology, gastroenterology, endocrinology, pathology, radiology, and we all get together and talk as a group.
I think as a specialist in neuroendocrine tumors, I would like to think that specialists are accessible to patients and complement what is available locally. And I think that's probably the biggest theme that I can say in terms of my own practice is the vast majority of my patients have local doctors, and we don't want to replace those doctors. We want to try to help be part of the team. And the nice thing about that is it allows patients to often get a lot of their care locally. And particularly for well-differentiated tumors that may be very slow growing, our goal is really to allow patients to go on and live their lives as normally as possible for as long as possible. I think that's one of the major themes that we try to have patients take away from the visit with us, is that hopefully we're adding to their care team, and we want them to keep their local team intact with the goal that we can all work together over the years.
Treatment options for NETs vary widely depending on where they originate and whether they are localized or metastatic. When I talk to patients about treatments, I would say that that's really a very optimistic, hopeful area because we have lots of tools in our toolbox.
There's just been one treatment after another that has been proven to be effective.
I think there was once upon a time where all neuroendocrine tumors were treated the same, and that is no longer the case. We now have different treatments for small bowel neuroendocrine tumors and different treatments for pancreatic neuroendocrine tumors, and some drugs that are approved and useful in one type of tumor are not necessarily useful in the other. And so finding the primary tumor so that we can at least say which type the patient has makes them eligible for certain types of therapies with expected response rates, as opposed to just taking a blind shot at it and see if it works or not. Most patients should have their primary tumor found and removed, in my opinion, and it provides multiple benefits in terms of preventing bowel obstruction, reducing pain, reducing symptoms, and there's the potential survival benefit. And the vast majority of neuroendocrine patients have multiple tumors in both lobes of the liver at diagnosis. The reason that you have to remove lobes in other kinds of cancers is because those tumors act like dandelions within the liver. There's a main tumor, but it spreads out with tentacles that are extending microscopically. And if you don't get a wide margin around those, you cut across them and leave cancer behind, and the tumor recurs quite quickly. And that is not the case with neuroendocrine tumors. They land in the liver and they are expansile, not invading, meaning they expand like a sphere and push the liver out of the way, which means we can actually just enucleate them, roll them out of the liver without removing a lot of liver. What we want to do is we want to coexist with the disease. We want to debulk it, get it down in volume. Having less disease, we believe, makes it much easier for the other treatments to help if they have to fight less volume of disease.
The guidelines currently for patients with a resected NET generally recommend monitoring with scans for 7 to 10 years following surgery. So I think that could put patients in a position where they may not be getting the needed monitoring.
Doctors have become much more sophisticated in integrating surgery and liver-directed therapies and other therapies with these treatments to the whole body. And as a result, patients are living longer and higher quality lives, and it's made a major impact.
PRRT is the shiny new toy. It stands for peptide receptor radionuclide therapy. Of all of our other therapies, this delays progression the longest. Additionally, its ability in some patients to shrink tumors is also fairly unique. So I think that it is a game changer in this disease.
PRRT, peptide receptor radiotherapy, has just been proven to be effective in neuroendocrine tumors, but I think we should be aware that there are new molecular targets, new types of medications that are being used as radiopharmaceuticals for PRRT, and huge advances in that field are about to be made over the next few years.
Even for patients with metastatic NETs, they may still be able to live a very active lifestyle and have good quality of life living with cancer. And I think that that's, again, it's a really important paradigm shift for how we think about cancers. And the more chronic cancers or the slower growing cancers, I think thinking about the word cure may not be the right way to think about it. It's, can we control the cancer and manage the cancer to allow you to have a good quality of life?
Neuroendocrine tumor patients, by and large, are among the most well-informed, intelligent, and supportive of each other community that I've ever encountered for any other type of malignancy. And I think that everybody who's diagnosed with a neuroendocrine tumor should do their best to connect with their peers who are also suffering from the same thing and realize that there's definitely hope. Not giving up hope, and in fact being hopeful and being surrounded by other people who are, is a tremendous benefit. I think people do better, they tolerate treatment better, and they enjoy their life better and live with their disease better. So I would encourage people not to prematurely give up or to lose hope.